Welcome, everyone. My name is Denise Egan-Stack,
And I'm Susan Boaz.
and we are here today to talk to you about OCD 101, OCD Treatment 101, and how it's modified to treat young kids. I'm going to be speaking from a clinical perspective, and Susan's going to be speaking from the perspective of a mom of someone who has OCD. But before we get started, I just wanted to say at the outset that we have an incredible amount of information that we're going to cover in a very short period of time. And it might be that you end this session with more questions than you had when you first started, and that's okay. We're really presenting this information as a way to help you understand as parents what treatment for your little kid should look like and what your role in that treatment should be. We just want to educate you about that. So by the end of this session, you will be, by all means, not an expert. You are really just starting your journey here. And you found the IOCDF, and we will be with you all along the way. I also think that there are going to be sessions that go on throughout the weekend that will answer some of the questions that you have. So stay tuned. Okay. Okay, so let's get started. Just wanted to cover a couple of basics just so that we all have the same knowledge base. We understand that OCD is a brain disorder, it's a neurobiological disorder. It affects about 1 to 3% of children, although we don't really know how prevalent OCD is in little kids like the ones we're talking about today, because they oftentimes have a very difficult time developmentally talking about their fears, their thoughts, and conveying stress to other people. And sometimes they can be secretive. But what we do know is that early onset OCD really does disrupt normal developmental milestones because it's generally occurring right around the time that education is starting. So, pretty significant OCD can interfere with engaging in school and developing normal peer relationships. So, it is really important to treat kids early. And so, kudos to you parents who are here today because you found this program, which means you are intervening early, which means it's going to have a very positive impact on your child's life. Also, just wanted to cover very briefly a couple more basics. The first one is that in order to be diagnosed with OCD, you have to have obsessions and compulsions. And obsessions are intrusive, unwanted thoughts, images, or impulses that create anxiety or distress in your child. And then there are compulsions, sometimes called rituals, that your child feels compelled to do to get rid of the anxiety that the obsessions cause. And when those obsessions and compulsions are so time consuming and they cause so much distress and interfere with functioning, like in school or making friends, an OCD diagnosis is warranted. It's just important to know the interplay between obsessions and compulsions because those are the things that we're going to try to interrupt in the ERP, which is going to be a basis of a lot of what we talk about today. Okay. Um, so let's just talk about some other basic information. We know because there's lots and lots of data that the best treatments for OCD are cognitive behavioral therapy using a technique called exposure and response prevention. We're going to call it ERP today, and medication in the SSRI class, which is a selective serotonin reuptake inhibitors. That's Prozac, Luvox, Zoloft. And sometimes when they're going to be combined. So in pediatric OCD, we start with cognitive behavioral therapy. But if the symptoms are moderate to severe and really interfere with a person's ability to engage in ERP, we might add medication. So there's a combination of both. But we're generally going to start with cognitive behavioral therapy for kids. Okay. And when we're doing cognitive behavioral therapy, we're going to look at this illustration here. This is something that was developed by Aureen Wagner, a pioneer in pediatric OCD. And she created this illustration to help people really get a sense of what happens in the OCD anxiety and avoidance cycle, which is here in the dark white lines. And that's when a child is triggered, their anxiety is going to climb. Their anxiety due to the obsession is climbing. They'll engage in a compulsion to try to feel better. And their anxiety will quickly drop, right? They will feel better in the moment, but they don't feel better for long before another obsession occurs. The anxiety rises and they have to engage in a compulsion again. That is the vicious cycle that becomes time consuming, causes distress, and interferes in a child's functioning. So, what we really want to do in exposure and response prevention is what we're seeing in the gray line, the lighter line. We are purposely exposing a child to what they're afraid of, okay, their obsession. Their anxiety is going to climb, but instead of engaging in the compulsion, we want them to ride it out. We want them to not engage in the compulsion and see that their anxiety will be coming down normally. They'll feel better without having done the compulsion, and that they're braver than they think, and it's easier than they thought it was. Easier said than done, right? Though that is a very difficult thing to do when you have a little child who is afraid that their parent's going to die if they don't say, I love you 100 times in just the right way. It's really hard to get them to stop doing that if it means that their mom might not live, right? And they're little and they have a hard time understanding that and explaining it. But this is the treatment that we're going to talk about today and how it is modified for little kids. So, like I said, there's lots of data to support the fact that this is effective in treating OCD. There wasn't a lot of data, though, in how that was going to go for kids that were little, like 4 to 10 or 5 to 8, until there was a study called the Pediatric Obsessive Compulsive Disorder Treatment for Young Children. In the field, we call it POTS Junior. And the information that we're going to be presenting today is based on that study, which is a really important study, and our clinical and personal experience. Okay? So let's talk about how we take the ERP that works for everybody and modify it for little kids. I think first and foremost, as parents, you need to know that if your child is in treatment and they're little, they're in treatment for OCD, you need to be involved. This is a parent based, family based model of treatment. That is very different from individual therapy for, OCD for adults or teens. A lot of times it's a one-on-one thing, but for little kids, families are involved in all phases of treatment. Okay? The other thing is that clinicians need to take the time to understand the family dynamics, what's going on in the family, with particular attention to how parents respond to anxiety in the family. Okay. So sometimes parents, they punish, or sometimes parents blame, or sometimes parents swoop in to save the child, all very well intended and all hoping it's going to help, but it never really does. There's a lot of backlash. So the clinician really needs to take the time to understand what's going on in the family, which is different from traditional CBT for OCD. And the third very important thing is that clinicians need to tailor treatment according to the developmental place of the child that you have. Okay, so that's going to mean a lot of different things, and we're going to talk about them a little bit down the road. But those are the three main ways that CBT treatment is modified for little kids. Okay. So as we said, parents are involved in all phases of treatment. Okay, the first phase is psychoeducation. Usually, when you're treating someone with OCD, you actually sit down with the person who has OCD and talk about what it is and what treatment is. But with little kids, you do this primarily with the parents. A couple of sessions without the child to talk to the parent about what explain the neurobiology of this disorder, explain the treatment. Sometimes it's really hard for parents sometimes they're seeing a therapist for the first time and they're anxious about it. Sometimes they have anxiety about the fact that their little child has a mental health condition. Sometimes they have a lot of anxiety about the actual treatment, because if you're explaining that this is face your fears treatment, parents are going to have a hard time with that, especially if they're used to rescuing their child from anxiety. So you want to give parents time alone with a therapist, adults only, to talk about this, because little kids look to their parents as a way to determine what they should think about something new. So if you have parents in a room that are anxious themselves, having issues understanding what this treatment's all about and how's this actually going to work when it's the exact opposite of what I think I should be doing for my child, a child might be looking at that and they can form their own opinions early on about, this is not something I want to do. So it's really important to give parents time to do that on their own. Okay. We also want to differentiate between the normal development and OCD. So a lot of times kids have just normal rituals that they've developed when they're little. They might have a particular bedtime routine that's enjoyable and fun for them. It brings them pleasure and peace. Or they might have a special seat that they sit at the dining room table for dinner every single night. Those things are normal. Like I said, they're not time consuming. They don't create distress. And then there's OCD, right? And that's when it's very time consuming, it's persistent, it causes distress, it's interfering in a child's functioning. That's OCD. But a lot of times you have to break that apart for parents. Sometimes parents want to put all things in OCD. That's not necessarily true. So you want to, during psychoeducation, not only are you meeting with the parents alone, you also then want to cover what OCD is, what it isn't, and then just have an opportunity for parents to talk about the emotional impact that OCD has had on them and their family. Okay. So parents only in the beginning. The other thing that we want to do for parents is we want to help them build their own skills because, again, parents are going to be a huge part of implementing this treatment, not only in session, but also at home. And again, if parents are anxious themselves, or if they're using blaming and punishment as a way to manage the behavior, or they're rescuing their child from anxiety instead of like helping their children face the anxiety, they're going to need their own skills for how to do this because this is oftentimes the exact opposite of what they've thought to do. Okay, so we want to make sure that we're teaching them how to reinforce behaviors by using a reward system. Susan will talk about that later. We want to help them learn how to ignore behaviors that we don't want to see, like whining. We also want to help um, parents know like how to teach them how to model facing fears. You know, what are, instead of avoiding the fears, parents themselves can model behavior. And that's a very effective way of teaching your child. We want to help parents learn how to stay calm because anxiety is catchy and children so oftentimes absorb the affect of their parents. So we need to teach them how to stay calm in a very distressing, anxiety provoking moment. We want to teach them the benefits of tolerating your loved one's anxiety instead of rescuing them from it. And again, we want to teach them that nagging, punishing, anger, and blaming do not work. Although we are all human. I'm a parent too of 3 kids. I'm a specialist in this, and I think I have engaged in the nagging, blaming thing. So no judgments here, but we really want to teach alternatives that are much more effective for treating your child's OCD. Okay. Um, let's take a second to talk about family accommodation. Intuitively, I've kind of mentioned this a few minutes before, but intuitively, we want to help our child feel better. When they are anxious, it's a parent's intuition to make them feel better. But when it comes to OCD, sometimes the ways in which we try to help children feel better by maybe washing our hands over and over so that they don't think I'm going to die or they're going to get sick, or avoiding having eggs in the house if they're afraid of getting contaminated by eggs. Those very things work in the moment, but then they create this vicious cycle, and you're going to get more distress, more upset, more interference in the family, and not less. And family accommodation occurs in 60 to 97% of families. So this is the reason why we're talking about it. It happens all the time in families, and it can last a very long time. It can last years if it's not treated, and it happens almost on a daily basis. So we need to talk to parents about the ways in which they're engaging in accommodating the OCD. And then we need to teach them why it doesn't work and what to do instead. We don't have the time to talk about all of that right now today. Susan and I do like hours long presentations on just this one topic. But the good news is there is a whole session on family accommodation on Sunday, and you're going to learn a lot about why it doesn't work and what to do instead. But very briefly, what does family accommodation look like in families? The need for routines. There might be a very set routine at night where the blankets have to be pulled all the way up tight, that the teddy bears need to be all lined up perfectly, and you have to say I love you the exact right way in the exact tone of voice, and that could last for like an hour. Reassurance seeking. Am I going to be okay? Am I going to be okay? Am I sick? Am I sick? Like repetitive behaviors, like, will you check to make sure my windows are locked? I don't want the boogeyman to come in. I don't want anyone to come in and take me. Excessively lengthy routines, especially in the bathroom. Pooping is an issue for people with OCD, especially kids. Is it all out? Have I wiped enough? Bedtime or dinner rituals, rage attacks, and parents doing whatever they can possibly do to prevent a rage attack from happening. And then a desire for symmetry. Things need to be lined up just right. And I take a second right now and ask Susan if any of these things sound familiar from when your child was really struggling with OCD.
I think we had all of them, but the one I always like to kind of touch on briefly is she was convinced that this always makes me laugh. This particular tree was going to fall on our house and that I would die. And so she would ask me hundreds of times a day, is there going to be a storm? What's the weather? Will the tree fall? Those were the questions that were being asked. And we did some work with her to say, let's talk about what you're afraid about. You're worried about mom dying. And she was like, no, I'm actually worried about being alone. So it wasn't my death that was actually the problem. It was just that she was going to be left alone in the house and she wasn't old enough to take care of the house. So, that question coming out over and over, at first I didn't know what it was. So I answered the question. But within a few days of realizing that I was answering that question hundreds of times and it was becoming very frustrating to the whole family routine, we realized that we were accommodating a behavior.
Mhm. And what did it feel like when someone told you that you shouldn't do that? Or what was that like as a parent to think about you were actually going to have to stop doing those things that were actually, so entrenched?
First of all, you're going to have a panic attack from the child, and that's going to be very difficult to work through, right? So nobody really wants to cause that. But I think the second thing is that, we all come into parenting with certain expectations of how we're going to parent. And when you have a child with OCD, you have to become a different parent in order to be effective. And in the end, you'll end up, it's not that you'll celebrate that they have OCD, but you'll have learned different ways of parenting that will make you feel great and that you'll use in other areas of your life. But the transition to needing to parent in that way can be very difficult. I had a lot of grief about, I wanted to be the mom that the child runs to. And I'm like, oh, honey, it's going to be fine. And instead, I'm the mom that's like, we can handle this. What's your technique you're going to use? And so it's actually been very empowering to her over time, but it's a tough transition as a parent.
Exactly. And so you can really tell how this part needs to be integrated in the therapy for the therapy to work, right? Because what if it isn't? Like what happens if families don't work on this issue? Like what happened in your family if you sort of slipped, or if you didn't do it, what do you fear would have happened in your family?
I mean, not doing it, the problem was she didn't have, if we didn't figure out ways to stop accommodating, she didn't have a life, right? Like she wasn't making it to camp. She wasn't able to play with her friends. She wasn't able to separate from the house, from her family. And so I didn't have a life. She didn't have a life. So figuring out how to stop accommodating is the way to shift back to life. Although I do want to just say for our parents that are early in the process that it's not like you're going to stop accommodating everything in a day. We're going to teach you some ways to slowly work with your therapist. And when you eliminate some things, honestly, it fixes some other things. It doesn't make sense that you can attack the smallest thing and it helps, but it really does. So I don't want anyone to feel like, oh, we're going to have to stop accommodating immediately. I have to be this incredibly strong parent. It's going to be a process. We're going to set goals and you'll kind of work your way there. But it gives everybody a life back.
Yeah. In fact, stopping everything immediately is not good because it's not sustainable. It's too hard. And from a clinical perspective, I would be, and I am worried about parents getting too overly ambitious or getting so burnt out that they pull all the stops out. That's going to really sour everybody on treatment, right? That's going to be like treatment dropout. That's going to be, see, this doesn't work. I knew it wasn't going to work. It's like, no, we need to go, when we work with kids, we say, go low and go slow. Like, so start little and go and pace yourself. So there is no expectation that you need to figure this out yourself or do it all at one time. The expectation is that you're just going to participate with the therapist in planning how to gradually remove yourself out of this so that your child can learn that they can face their anxiety and they're going to be okay. That is how we build confidence. That is how we build self esteem, helping your child get through hard things. But, you have a family you need to run. You need things to go smoothly. We just need to get to church. We just need to get to school. We just need to get to bed. It's very easy to accommodate, but the backlash is severe.
I always say it's kind of like math. You don't just suddenly throw a 6-year-old into a calculus class and say, it's calculus, let's get it done. Right? We work up, we do math, we do addition and subtraction, and we learn different ways of doing math. And then slowly over time, we figure out how to get a calculus. But when it's when it's family behaviors, it's easy to want to fix it immediately.
Yeah.
But I guess the thing I always say to parents is, I promise it will pay off. I promise it will pay off, but we're going to take baby steps first.
Baby steps. Yeah. So, right now we're just talking about what a family accommodation might look like in a family, but the Sunday session, we'll talk more about why we do it, why, what the negative impact is and what to do instead. So we can't just tell you not to do it. We have to teach you what to do instead, but Sunday's going to break all of that down for you. Okay. So just to recap, the way that we're modifying CBT for little kids is it is a family based treatment. Okay. Parents are involved in all phases of the treatment. The clinician needs to get a good sense of how the parents are responding to the anxiety in the family and help the family build up different skills for how to manage it. If they're managing it ineffectively, they want to have their own skills for how to managing it within the family. And then talking about family accommodations or other family processes. Okay, so that's the first thing that we're doing. That's with the families. But we also need to modify the CBT for the child based on their developmental place, right? They have a harder time understanding things like thoughts. They have a harder time rating their anxiety. They have a harder time expressing distress. So we have to change the way we do psychoeducation with the child and the way that we deliver the treatment. Okay. So, psychoed session 1 or 2, probably with parents, you'll bring the child in after the parents feel clear about what the disorder is and clear about what the treatment is and clear about what their role is going to be. Okay. The psychoed for the child is really going to be about helping them externalize OCD from themselves. Okay. You are not OCD. And so, one way that we can do this is helping them maybe like draw an OCD monster. Okay. Sean Shinnick, also involved in the IOCDF, he has a whole program called Draw Your Monster. And it's all about helping not just children, but everybody with OCD like name their fear as a monster and draw it. And it's really cool and it's really effective. But for little kids, it's a developmentally appropriate way to help them understand that OCD is a monster. And that you can help them understand that that monster is what's putting those, those thoughts in their mind. And it's just a way for them to sort of conceptualize it. um a lot of times they really can't even understand it beyond like I'm the boss of my OCD monster. So language is really really important when you're trying to help a child understand what OCD is. The OCD is the monster and the treatment is about you bossing your monster around. Okay, so their ability to conceptualize this is really just based on their own development, and a therapist just really needs to be willing and able to meet the child where they're at. um, the other thing, like when you're doing psychoed with your child, the parent's role often in that meeting is to kind of translate for the therapist. You know your child really well. And so if I'm using an analogy or if I'm, like bossing back, like the parent might have a better word for it, or they may have a better way of translating what I'm trying to say to their child so their child gets that better. That happens often. Okay. Susan, do you want to say anything about Meg and how she like sort of understood OCD at an early age? What was effective in helping her just kind of get the idea that OCD was not her, it was not real?
Yeah, so she had a couple different names as she got older. Her original one was a worry fairy, and it was a little creature that rode around on her shoulder. And the trick to us was that it wasn't, there was a difference between what Megan wanted to do and what the worry fairy was asking her to do. And that allowed us to talk to her about things differently. What is the worry fairy asking you to do? What would you like to do? And then, even if we were accommodating the behavior, we were clear that we were not doing what Megan wanted to do and that we would find a way to get there. And it removes a lot of the blame of like, why won't you just get on the swing, for example, versus would you like to get on the swing? What does the worry fairy telling you can do? And then we might be able to say, well, what do you think you could do even though the worry fairy is really loud today? Could you at least walk by the playground? Is that a step that would be acceptable? So it just changes all of the language of conversation within the family, from blaming the child or having the child feel bad about what they can't do to fighting the worry fairy so that you can do what you want to do.
Yep. And as a therapist, when you're doing this with a child, you want to be as hands-on, active, and as engaged as possible. So you want to draw things on big pieces of paper. You want to build things. You really want to get this, the little into this whole thing and like engage them in it. And again, not only is it important for the parents to be a part of it because they can help translate in the moment, parents are going to be using this language at home, right? So, like Susan said, like out of the session, Susan's like, what's the worry fairy telling you to do? It's a way to have continuity between sessions and at home and using a language that allows Susan to align with her daughter against the worry fairy versus it being like Susan against her daughter, right? So it's important that we externalize OCD. And for little kids, we need parents' help to do that. And we need to be meeting kids where they're at and be active and engaged and fun while we're doing it. Okay. So we've taught the child what OCD is and what treatment is, and now we actually have to do the treatment. So one thing that we do when we're treating kids with OCD or anybody with OCD is we want them to be able to rate their anxiety, right? So we want to know how they're doing in a session. We want to know how anxious a certain trigger gets them or how anxious they are in the middle of an exposure session. And, with adults, we use a SUD scale, subjective units of discomfort scale, 0 to 10, 0 to 100. For older kids or teens, they might use a fear thermometer, but for little kids, like the ones we're talking about, can't really do that. You really have to simplify that for them. So a rating scale might just be like a 3 faces, happy, neutral, sad. Or like the picture I have here on the slide, you could use like other objects like cups, stacking cups of various different sizes just to help them try to get a sense of how anxious they are. But still yet, there might be some kids who simply just can't utilize that kind of rating scale, even if it's very simple. And so in that moment, a therapist and parents really just need to depend on behavioral cues as a way of sort of determining how anxious the child is in the moment. And for any of those of you, like, I guess all of you here, like, what it's like to have an anxious child. I know what it's like to treat anxious children. They can go from 0 to 100 in a second with their anxiety. Sometimes it's all or none. And so you really need to be prepared for that. Okay. ERP tasks. So everybody, all the adults need to model an approach behavior in the face of a fear. So if there's an egg and a child is very anxious about getting contaminated from egg, raw egg, salmonella, whatever, or just, I don't know, like being grossed out by sticky things, adults in the room can approach that in a very different way. Like they're approaching it, showing the child that there's other ways of engaging with that feared stimulus. It could be a dog, it could be anything, right? And we also need to break down the tasks. Susan's going to talk about this again in a moment, in very small pieces so that the child can gradually be exposed to what it is they're afraid of. Okay. Sometimes you can jump around with kids, but I think it's actually important in the beginning to start small and give the child an opportunity to sort of tackle things in a manageable way so that they can see that they're successful. And then you're going to kind of get buy-in and then you're going to get some momentum. Okay. But it's a skill to be able to break down these tasks into smaller pieces. We also want to use, ERP is a game. You got to be fun. You got to be funny. You use humor when appropriate. Some symptoms you can be funny about. Like if someone's got something sticky on their hands or like, it's chocolate and they're afraid of getting sticky, I read in one of the papers when I was like a young clinician and I loved this example. Melt a Reese's peanut butter cup in your hands and it gets all yucky and the therapist can be all goofy about it and start licking it. And the kids all, the child's laughing and it's kind of fun. And you're just using humor in an anxiety provoking moment to sort of change the way things are going. And any kind of change is going to be helpful, but it's also going to engage the child in what it is you're trying to do. But you got to model these things. So ERP is a game. Let's see. Do you want to add anything here, Susan, about just ERP for little kids?
Yeah, I mean, I think it takes a lot of confidence and I think it also takes a lot of strategy. So you have to really sit down with your therapist or your family and really kind of figure out what you're going to do. It demands some level of planning. So I know that's tough sometimes, but it does kind of need that. So I think
Yeah.
we'll talk a little bit now about how to start to tackle ERP and break it down into small steps on
Yeah.
this next slide.
I just want to note one more thing before we get started on that is It's also really important to know that kids have a very short attention span. So you are not going to sit with them for long periods of time to do this. It needs to be like quick and effective. It needs to be like fun and engaging, make your points and move on. Parents are in these sessions. Parents are watching how the therapist does it. Parents are gaining confidence from their own planning part of the process and their own like engaging in the session with the therapist. They're engaging also, they're learning from the therapist, because remember, you're going to go home and you're going to need to do these things yourself, and the more continuity we have, the greater the likelihood that the treatment will be effective. one
Right?
last thing one last thing for kids: rewards. How do you keep them motivated to stay doing these things? A good reward system is always part of the plan. Again, Susan's going to talk about that in a second. So it's a family-based treatment model. Parents are engaged in all sessions. We need to give them the skills to do the work. We need to talk about giving them skills for not accommodating anymore. For the little kids, we need to modify how we explain OCD, how we explain treatment, and then how we do treatment. Therapists need to be flexible. Parents need to be involved and flexible also. But there are two skills that Susan really is going to get more into, because when you are at home and you are having to do these things on your own, it's super important that you really understand this concept of breaking down a fear, and you really understand the concept of reward. So Susan's going to talk about that from her parent perspective. Go ahead, Susan.
Yeah, so I like to say, if someone told you today that you, in an hour, were going to jump out of an airplane without a parachute, you would probably have a panic attack. And I like to say that because that's how your child's OCD fears feel to them in the moment, like they're being asked to jump out of an airplane without a parachute and no one's helping them. And so understanding that fear can help you understand why, if the child is afraid, let's make something silly up, to put on their soccer shoes, and you're asking them to put the soccer shoes on and tackling this giant thing of this enormous fear of these soccer shoes, it doesn't really matter why they're afraid of them. We've got to work up to it. We've got to take baby steps. Just like if we were going to jump out of an airplane, we might say, well, actually, we need to learn how to put the equipment on our backs, and we need to look out of the plane first. And in fact, I have an intense fear of heights. So I might say, can I jump 3 or 4 times off of a wall before we actually go up in the plane, and let me see how this equipment actually releases and works? So that's what we're trying to figure out how to do for a little kid's brain around a big fear that maybe we don't fully understand. There are always tiny steps to every single fear, and we're going to have some breakout time in a few minutes where you can ask some questions about those. But I love this illustration, because if you said to 2 people, hey, I need you to race to the top of this ladder, you'll see that on the left, there's little tiny rungs, and that child has shot straight up that ladder. Whereas on the right-hand side, you've got a child who can't even reach the first rung. So there's no way they're going to get on that first rung. Never mind, even if they did leap bumped on that one, how are they going to get to the second? So what we're trying to do is find the tiniest rungs that they can possibly go. So kids scared of an egg. I don't care why they're scared of the egg, but they're terrified of eggs. Any kind of eggs in the room and they have to leave and go upstairs. They scream and have a hissy fit. Nobody can cook with it. They're asking constantly if there's eggs in the recipe. Well, you don't have to eat the egg. It's not the first step. That's way too big. In fact, maybe you just draw a picture of an egg. That's always a really easy access point, is drawing a picture of something. It's not in the room, you're just drawing it. Maybe you're going to then put an egg in a room, but it's on the other side of the room. And maybe it moves incrementally, slowly closer to the child over some period of time. You might actually cook something and have a taste of it, or maybe you just help crack the egg and other family members eat the item with the egg in it. There's lots of ways to break this down. And it really depends on what the child's fear is. Personally, I'm big on including even little kids in the process of like, what would be the easiest thing to do about an egg? You know, would it be to sing about an egg? That's another one that I really love. We sang about things all of the time that we couldn't really do. So if we were scared of an egg, we might make up the egg song and we might sing the egg song, you know, for a few days. So eggs are lovely, eggs are mean. I don't think that eggs are green. That is actually an exposure, right? So I just made that one up. Actually, we were not scared of eggs. We were scared of throwing up. All kinds of things to be terrified of. So, and each of those, we're trying to break it down and figure out, how do we approach the egg in a way that is not as scary to the child? What I really want to emphasize here is that we're going to talk about rewards next, but The first thing I want to say in rewards is sincerity of praise is so important to kids, and they know when we're being sincere about it. And so when we first start this process and a child is terrified of an egg and it seems a little bit silly to us, we don't understand the true terror that they're trying to jump out of an airplane. We have to kind of acclimate our brains to that. But once we begin to understand that singing the silly egg song is actually an act of great bravery, the first thing we need to do is acknowledge that. And that's the first part of breaking down the fear, is to kind of understand what the baby steps are. And the second part is to wrap everyone in the family's head around the fact that this is really tough for this person and we want to reward that behavior. So on our next slide, we talk a little bit about rewards. This is always my favorite part of building an OCD program, is because kids are super motivated by rewards. First off, praise, but secondly, what else can you do? So I'm going to move to something that we had with Meg very specifically, which was that she asked a lot of questions about the weather and this tree that was going to fall in the house and take me out and leave her alone. The first thing I had to do before I could even build the reward program was figure out how many times she was asking in a day. And I'm going to go ahead and tell you that it was over 100 times. So it was a pretty consistent part of a day in our house, was Megan asking for reassurance about the weather. So the first thing that we did was figure out how many times that was being asked. And then I involved her in saying, okay, today you asked 100 times. How many times do you think you might ask tomorrow? Sometimes she'd be like 3. And I'd be like, okay, that seems a little hard. How about we go with 95? You have 95 times that you can ask. And so we're trying to reduce the behavior, but not like dramatically at first, right? Because I want a very achievable goal. Asking 3 times was clearly not going to be achievable and was going to cause lots of panic attacks. So let's say we set 99 times. Well, then we would create a little reward jar where we had 2 jars, for example, and we had whatever you want to put in the jar, marbles or cotton balls. And each time she wanted to ask me a question about the weather, I would say to her first, go move a marble from the question jar. And so she would move it to the answer jar, and those were labeled in whatever way is age appropriate. And it did a couple things. It actually broke the ritual of her asking and my responding, because now I'm giving her a different answer and she's having to do an activity, or she's having to redirect her own brain to do the activity first. So that was super helpful. And by setting a really achievable goal, so we almost always made it, like towards the evening, there'd be like 5 cotton balls in there. And I'd be like, hey, do you want to use a cotton ball right now? Or do you want to save that for like closer to bedtime? And so she got to make some choices and fight the worry fairy, even though she didn't know that's what she was doing. She was already fighting back and bossing the worry fairy. I'm not going to ask that question right now. I only have 5 cotton balls left. I'm saving those for bedtime. As long as we ended up with 1 cotton ball in that jar at the end of the evening, she would earn a point towards rewards. So much fun to create reward programs. You would not believe the creativity of your children when you ask them to help you build a reward program. So one of Megan's rewards was actually making her dad eat butter. I don't know why that made her laugh so hard, but it was one of her great joys in life was to, and we actually worked up on that. Luckily, her dad did not have a high disgust factor. So he would eat butter with hot sauce on it. He would eat butter in his coffee. Like, she was constantly thinking of new ways to basically torture her poor dad. And he was a willing participant in this because it made him feel good that he was part of the reward system, and made her feel really good that she got to boss not only the worry man or the worry fairy, but also her dad. But there's lots of ways you can do rewards. So you can take $5 and go to the dollar store and let them pick those out. And then when they earn 5 points, maybe they get to go to the reward closet and pick one of those dollar rewards out. It might be something big that you're working up to over the week. Like, if you can leave 1 cotton ball in the jar for 5 days this week, then we're all going to have a pizza party on Friday night. I like to involve family in reward systems. I think that makes it a lot of fun. And we'll talk more about siblings in another session and how to involve them as well. But that's kind of the way it works. I also think screen time privileges are huge. And I know that's a tough one to tackle, but sometimes screen times are used as an escape from anxiety so that you never reach the top of the worry hill. They get distracted instead by screen time. So I personally use screen time as part of the reward system for younger children. And we would have coupons for screen time that they could earn. And that way, screen time didn't become an escape for anyone. It was more something that was part of the entire process. The other thing is that we turned almost everything into a game. So in addition to rewards, like if we were playing Uno and someone drew a draw 5 card, Megan would have the option of actually going and touching something scary. Like maybe the egg was sitting on the counter and I was like, well, you can either draw 5 cards or you can go touch the egg. Either one, it's your choice. And so she could choose whether she was going to fight that. But even that process of choosing helped her understand that there was something she wanted to do herself and that she had control over that. And she could choose in that moment to fight or to not fight. Rewards are fun. I encourage you to ask lots of questions in the next session if you have specific behaviors that you're trying to eliminate or you're trying to figure out how to build rewards that are appropriate for your child's age.
Yep. And I think the thing about a rewards program is it's so effective if it is really clear what the child needs to do. It's really clear what they get when they do it, and then that is consistent. Rewards programs can go awry very easily, so it's good to make sure that you're running your ideas through by your therapist just so that they can, problem solve if things seem like it's not quite so clear, because trust me, it could become a real problem. So you want to make sure it's clear and consistent. But I think we're out of time and we've covered all the material right now. So what we're going to do now is we're going to go into breakout sessions, and we're going to talk about, you're going to be, you guys, a chance to talk about with each other what kinds of family accommodation behaviors you might see in your family, or how you might, what fears there might be that you guys can break down into smaller pieces, and what kind of reward system ideas you have. And so people who are new to this whole process might be asking questions, and then families that have kind of been through this, they might have their own experience. They can share their experiences with everybody. So we're going to go for about 15-20 minutes of discussion. Then we'll meet back here again for a wrap up as a group. So see ya in the breakout sessions.